Hello, everybody, and welcome back to MBME 29. All of these questions that you're about to see are original. They are made by me. They are not copied from the MBME, but it's everything that I think you should know by the time you take your Step 1 exam. So let's dive right in. Question 151. A 16-year-old girl is referred to the endocrinologist for evaluation of primary amenorrhea. She is short for her age and has a broad chest with widely spaced nipples. This is Turner syndrome. She has 45X in 12 out of 20 metaphases and XX in the remaining cells. Which best explains the patient's karyotype? The answer is postzygotic mitotic non-disjunction. So you have two cell lines that are different, which is mosaicism, and mosaic Turners arises from mitotic post-fertilization events. This is from non-disjunction early in embryogenesis. So some of the daughter cells lose an X and the others are normal. Here's our explanation. Meiotic non-disjunction would be all cells affected. It'd be uniform across the board, just the X, for instance. X-linked deletion is the loss of a gene, not a whole chromosome, so it wouldn't create the 45X karyotype. Genomic imprinting would have different gene expression, not chromosomal loss, and balanced translocation would not have monosomy. So up to 30% of Turner syndrome cases aren't 45X across the board. Some have mosaicism, so their body is made up of two different cell populations. So Turners, remember there's mosaic Turners caused by mitotic error, postzygotic, and non-mosaic Turners, which is a meiotic error, which is all cell lines affected. In our next question, a healthy 28-year-old woman comes for preconception counseling. Her husband has a family history of autosomal recessive metabolic disorder that affects glycogen degradation. His younger brother was affected, but both parents are healthy. The disorder affects 1 out of every 90,000 individuals in the general population. The patient has no family history of genetic conditions and is not consenting. Based on this information, what's the approximate probability that the patient is a carrier? So here we use Hardy-Weinberg. Disease incidence is Q squared, which is equivalent to 1 over 90K. That's the first step. And then we take the square root of both sides, which gives us 1 over 300. And the carrier frequency is 2pq. So 2 times q times p gives you 1 over 150. All right, so this is the formula you need to know for Hardy-Weinberg equilibrium. That's the rare disease in question. So we take the square root, 1 over 300, and we get 150 as our answer. And the reason that we know a p is 1 is because p plus q is always 1, and q is super, super small. And so P is very close to 1, so I approximated it as 1. That's Hardy-Weinberg equilibrium. Okay, here we have a 62-year-old woman, could also be a man, hence the relevant demographic. Undergoing chemotherapy for breast cancer, presents with easy bruising and small red spots on her lower legs. She denies recent trauma. On examination, there are numerous 1 to 2 millimeter non-blanching erythematic macules on the shins and forearms. Her gums are slightly bleeding during oral exam. Which of the following is the underlying cause of these symptoms? So it seems like she has chemotherapy-induced thrombocytopenia. There's the photo of our patient. This has led to Petechiae. So the answer is going to be suppression of megakaryocyte precursors. So let's look at the brief explanation. Bone marrow suppression has led to Petechiae. Autobody-mediated red blood cell destruction would be spirocytes and jaundice. Inhibition of vitamin K affects the coagulation cascade, not the platelets. Activation of plasminogen to plasmin would cause bleeding from multiple sites. That's the increased D-dimer seen in DIC. Congenital deficiency of factor VIII would be hemophilia. So really tiny, non-blanching, super small petechiae indicates that we probably have a primary hemostasis problem. You should think of low platelets whenever you see this, or platelet dysfunction. So you got petechiae and mucocutaneous bleeding. You have in the gums, epistaxis, and that means we have a decreased platelet count. It's impaired production from the megakaryocytes because of all the destruction. So primary hemostasis involves the platelets, cause of petechiae, purpura, and mucosal bleeding. Secondary hemostasis would be coagulation factors. That's deep tissue, joints, muscle bleeds, and large ecchymosis. So a protein C deficiency would be a risk for thrombosis, not bleeding. Okay, so here's what's happening. We have the small red-purple dots showing up in the skin because there are a lot of vessels under stress there, because you don't have enough platelets and so the blood is leaking out. So there are not enough platelets. You can see this because she's getting chemotherapy. Chemo hurts the bone marrow, so you can't make the platelets. No platelets means bleeding, petechiae. That's what's happening here. Here are the traps to avoid. Vitamin K relates with PT. Hemophilia would be joint bleeding. Red blood cell problems would be anemia. Too much plasmin is DIC. All right, in this next question, a 45-year-old man begins a new medication that acts as an allosteric inhibitor of the liver enzyme involved in fatty acid oxidation. Kinetic analysis with and without medication shows a rightward shift on the curve. Maximal velocity remains unchanged. The answer is increased Km because this is allosteric inhibition. So here's allosteric inhibition. It alters the active site. Here are the differences between competitive, uncompetitive, non-competitive, and mixed. The Vmax always goes down except for competitive. And here, the effect on the Km is increased, and it's binding to the enzyme. That's competitive inhibition. And it's important to know in competitive inhibition, you're binding to the active site, and allosteric, you're binding elsewhere. So here we have an allosteric inhibitor, not a molecule that's competing for that active site. It's all about the active site, because competitive is reversible with the increased substrate, and allosteric is a regulatory site that affects the enzyme conformation. And it's the shape of the curve that can tell you if it's competitive inhibition versus allosteric. So for instance, here would be a simple one, and here is an allosteric one. And the way to think about this is in our simple one, here you have an enzyme, let's say, and that makes this the active site. And so you have a substrate that comes and binds right there. Whereas in the allosteric one, we have an effector that binds right here, and it causes that different looking graph. All right, there we go. So here's the entire chart. So you can see allosterics working on different enzymes. Hyperbolic would be competitive. Sigmoidal is allosteric. Okay, in the next question, we have a 27-year-old woman presenting with acute pelvic pain and light vaginal spotting. She reports her last menstrual period was 7 weeks ago. Medical history is notable for prior chlamydia infection 2 years ago treated with antibiotics. Urine pregnancy test is positive and transvaginal ultrasound shows no intrauterine gestational sac. Serum beta HCG is 1,800. Which of the following most likely contributed to the patient's condition? It's a history of treated chlamydial infection. They could also say it's some other gonococcal or gonorrhea infection that she had. The reason being chlamydia can cause tubal inflammation and scarring, and that predisposes you to ectopic pregnancy. High beta HCG points to an ectopic gestation. Look at that level. So on step 1, the big risk factors for ectopic pregnancy are going to be pelvic inflammatory disease that's most often caused by chlamydia or Neisseria. Also tubal surgery that can leave behind scarring in a previous ectopic pregnancy increases the risk, and intrauterine devices and in vitro fertilization. So it's going to be some previous infection, history of treated chlamydia infection or gonorrhea that's going to be the answer to the question like this. All right, so there's your explanation. Here are the trap answers and why they're wrong. I think we're going to move on to the next question. All right, so here we have a 6-year-old girl, could also be a young boy as well, is brought to the pediatrician for evaluation of worsening scalp tenderness. Her parents report that she has been more irritable and tired of the last week. Physical exam shows a soft, mildly tender mass on the left parietal bone. CT scan shows a 3-centimeter lytic lesion in the parietal skull. A biopsy reveals numerous mononuclear cells with nuclear grooves and infiltrate-rich eosinophils. We have positive CD1A and S100. All right, so when I'm looking at this question, what I see is a young person. They have some lytic skull lesions. They have eosinophil infiltrate, and then S100 positivity and CD1 positivity. So you should look out for those skull lytic lesions, the tenderness over the occipital bone, and all this should make you think of Langerhans cell histiocytosis. So the pathophys here is there's clonal proliferation of the Langerhans cells. These are specialized dendritic cells, and they call them Burbeck granules. They're like tennis racket shaped. And in the immunohistochemistry, will show CD1 positivity and S100 positivity and Langerhans positivity. All right, so look out for bone lesions. Also, it's seen with the skin rash, and it can involve the bone marrow, the lungs, the lymph nodes, the endocrine glands. So you have a child with lytic bone lesions, a skin rash, recurrent otitis media, and a mass infecting the mastoid. So it's Langerhans cell histiocytosis. You see Burbeck granules and CD1A, S100, and Langerhans is positive. Look for the bone lesions. And if you see an eczema-like rash, diabetes insipidus, indicating posterior pituitary involvement, then it's HSC triad. So here are the trap answers: osteoid osteoma, nocturnal pain relieved by NSAIDs in the femur and the tibia, not the skull. Ewing sarcoma is onion skin, periosteal reaction, presents with systemic symptoms. Aneurysmal bone cyst would be blood-filled space on imaging, typically multiloculated without that CD1A positivity. And you should look out for those Burbeck granules. Now, it's not enough to just think of bone lesions and you're done on step 1. There are several conditions which can cause bone lesions. And the one we're talking about is LCH, which is Langerhans cell histiocytosis. And that's in children. The location is going to be the skull, the ribs, and the long bones. In this condition, you see lytic bone lesions, skin rash, recurrent otitis media, diabetes insipidus, the Hanschüler-Christensen triad. And really look out for that CD1A positivity. Now, there's another condition that can cause these lytic lesions, and that is Ewing sarcoma. And Ewing sarcoma is commonly seen in boys that are younger than 15. They have long bone, lytic lesions, diaphysis, pelvis, the ribs. And there you have very painful, often systemic symptoms. They have fever. And one thing with Ewing is going to be an increased ESR. Now, another lytic lesion problem is osteosarcoma. That's bimodal, so elderly patients with Paget and radiation are going to be the demographic for osteosarcoma, or they could just be like 10 to 20, but it's bimodal. So not in between, more on the extremes of the age chart, but not right there. You'll see pain, swelling, and that has a sunburst pattern with a Codman's triangle and malignant osteoblasts. And the last lytic lesion that you should know is metastasis to the bone that's seen in adults. And typically that involves the axial skeleton, so the spine, the pelvis, the ribs, the skull. And maybe you should also think of a solitary bone cyst as another option. That's seen in children and adolescents. In the metaphysis of the long bones, it's incidental, and it's like a fluid-filled cavity. It's benign, it's not malignant. So, just to sum all this up, Langerhans cell histiocytosis is going to be seen in children with skull lesions and a rash. It's a dendritic problem. Ewing would be, they have onion skin. They also have that translocation for Ewing as well. Osteosarcoma has the sunburst near the knee in the teens. Metastasis is commonly seen in adults. It's the most common malignant bone lesion overall. And then cysts are just benign. Okay, so those are all of the lesion associations you need to know for step 1. All right, so for this one, we are conducting a study where we start with the exposure status, exposed versus unexposed. And then we track them over time and we compare the outcomes. That's a cohort study. And so relative risk is used in these studies. Odds ratio is used for case control, and cross-sectional is used in a prevalence ratio. These 3 things are what you need to memorize. Cool? Okay, in this question, we have a 62-year-old man admitted to the ICU with acute necrotizing pancreatitis. Day 3, he develops worsening dyspnea and hypoxia. He's intubated. Chest x-ray shows bilateral diffuse opacities. PaO2 to FiO2 ratio is 130 millimeters mercury. Bronchoalveolar lavage shows no organisms. Lung biopsy shows alveolar septal thickening and eosinophilic material lining of the alveolar spaces. What describes the primary mechanism responsible for his lung findings? Okay, so this guy has ARDS, and the answer is neutrophil-induced injury to pulmonary epithelium and endothelium. It's non-cardiogenic cause of edema. This is acute respiratory distress syndrome. And the timeline is interesting here because this develops within days after some sort of trauma or sepsis event. The findings are dyspnea, hypoxemia. Hypoxemia is low oxygen in the blood. Diffuse crackling and bilateral fluffy infiltrates on the chest x-ray. Now, the pathology here is a cytokine storm in burn patients. That causes neutrophil activation and then injury to the alveolar epithelium. And that increases the vascular permeability, causing protein-rich exudate to fill the alveoli, and that causes hyaline membrane formation. Okay, so the big keyword to look for is hyaline membrane formation. On autopsy, it'll be firm hyperemic lungs with widened septa and hyaline membranes. That's ARDS. It's not immune complex deposition. That'd be glomerulonephritis or vasculitis. It's not type 2 pneumocyte loss. That's seen in neonatal RDS, but acute respiratory distress syndrome involves both of them with neutrophil predominance. Type 1 hypersensitivity would be anaphylaxis and asthma, IgE mediated. It's not relevant here. And fibroblasts would be idiopathic pulmonary fibrosis. ARDS is acute, not chronic interstitial lung disease. And this is a pretty serious condition. It's something like 40% of patients who are in the ICU with ARDS are not going to survive. All right, so here's the breakdown. Macrophages release cytokines like TNF-alpha and IL-1, which summon neutrophils. And there's that inflammation because of trauma, sepsis, or severe pancreatitis. The neutrophils dump enzymes and ROS that shred the alveolar epithelium that leads to protein-rich fluid entering into the alveoli. And those guys make the hyaline membranes that you see. And the patient then has severe hypoxia because of these hyaline formations. The lungs aren't working very well, and the PaO2 ratio drops, Berlin's criteria for ARDS. So this is neutrophil-induced injury to the pulmonary epithelium. All right, in our next question, we have a 72-year-old man, or it also could be a woman, as seen in this question, has a history of poorly controlled hypertension, type 2 diabetes. This is probably going to be a stroke something. Yep, she has wide flailing movements of her left arm and leg. He is alerted and oriented, could be male or female. Neurological exam reveals no cranial nerve abnormalities. MRI shows a small infarct in the deep brain structure. Which one is it? It's the subthalamic nucleus. Hemi-ballismus, damage in the contralateral subthalamic nucleus. It inhibits things through the indirect pathway. And so if you lose that inhibition, then that causes uncontrolled movement. And this is often due to lacunar strokes in the setting of hypertension and diabetes. So here are the associations, but the answer is going to be C, the subthalamic nucleus. So you can see it right there. Now, the associations, hypertension would lead to lacunar strokes. So that's like the small vessels deep inside of your brain, including the basal ganglia. Non-ketotic hyperglycemia can mimic hemi-ballismus due to metabolic insult to the basal ganglia. Huntington's disease would have chorea, not hemi-ballismus. And Wilson's would be copper deposition of the basal ganglia. So here you have an ischemic stroke of the subthalamic nucleus, often lacunar. The thalamus becomes overactive because you lose that indirect pathway, the decreasing of the inhibition. And it's unilateral because it's just going to be on that one side, the contralateral limbs. Now, there's a difference between chorea and hemi-ballismus. Chorea is involuntary, regular, purposeless flowing movements. Affects the distal limbs, the face, and the trunk. Continuous, but unpredictable. It's dance-like. Hemi-ballismus is sudden, wild, and flinging. Unilateral. Much faster. Chorea is in Huntington's and Sydenham chorea. Affects the caudate nucleus, whereas subthalamic nucleus is contralateral hemi-ballismus. All right, this next question is going to be really easy. Typically, it's going to be a young boy, but it could also be a female. 9-year-old girl is brought to the clinic because her teachers report that she often daydreams during class, forgets assignments, and seems to struggle with completing tasks at home. She says she takes hours to finish homework unless supervised. No history of seizures, trauma, vision, and hearing issues. She meets developmental milestones and is otherwise healthy. They're going to give her a treatment. She's got ADHD. What are they going to give her? The answer is C, promotion of presynaptic dopamine and norepinephrine release. So she has inattentive ADHD. So you give her a stimulant and it increases dopamine and norepinephrine release in the prefrontal cortex. So inattention with hyperactivity across settings during childhood, the first line stimulant would be methylphenidate or amphetamine salts. These guys increase the presynaptic release of dopamine and norepinephrine, and also the attention. The reward processing is dopamine, the attention is norepinephrine. NMDA receptor blockade would be in ketamine, unrelated to ADHD. Potentiating GABA would be benzos, barbiturates, and that would be sedative. Serotonin reuptake inhibition is used in depression and anxiety, and alpha-2 antagonist would increase norepinephrine, but not in a controlled way. They're adjunctive, not primary therapy. So you can give them as part of something, but it's not the primary therapy. And this is crazy because 10% of children in the United States are diagnosed with ADHD. So distractibility, impulsivity, poor task completion as early as kindergarten. You give them stimulants, they power the brain, boosting dopamine and norepinephrine. It just lets you focus. So we got a 9-year-old girl, inattentive ADHD, promote those presynaptic dopamine and norepinephrine release, and you're good to go. Hopefully you guys have found this helpful. If it was, like and subscribe, and we'll see you guys in the next video.